Now I get to tell you about the ketogenic diet. Is anybody here familiar with the ketogenic diet? Great. If I was to tell you before you became familiar with it that you could eat a lot of fats and stop seizures, you'd think I was nuts. But actually, this diet has been around for almost 90 years. And although it's had a mixed history, more recently, physicians around the world are getting more comfortable with it and using it quite often. So the ketogenic diet, fatty foods fight fits. This doesn't look too bad. Of course, you had lunch. I hadn't had my lunch yet. But this is a variety of foods that are included in a typical ketogenic diet. But what exactly is the diet? It's a high-fat, low-carbohydrate medical regimen. Medical regimen is there because this is not a diet you would start at home on your own. This is a medically prescribed regimen. And it's not just the high fat that's important, it's also the low carbohydrate. That's equally, if not more important than the high fat. But in combination, the diet is very effective in intractable epilepsy. Now, if you look at a food pyramid that were popular a while ago, and I know it's changing now. Carbohydrates are losing their preeminence as the basis of most diets. But anyway, none of us could get to 65% fat if we went to McDonald's every single day of the year for each meal. You just can't get that much fat in. It's got to be a specifically formulated diet. So in the ketogenic diet, about 2/3 of the food is fat, about 30% protein, and just a little smidgen of carbohydrate. Just enough to grow on. By weight, it's 4 grams of fat for every 1 gram of carbohydrate. And every single meal, every single snack has to be weighed out specifically by the family in order to get to that optimum ratio. And compared to so here it is in graph form, what I just said, and then the typical American diet is about half carbs and a little more fat than protein. But that shows the difference in distribution of the food types in the two kinds of diets. Now, the ketogenic diet is not just an American thing. It's worldwide, and the gray represents all of the countries of the world, areas of the world in which the diet has been adapted. Even in Asia, which has a very un-American kind of diet in many respects, dietitians can creatively make the diet work, even with local customs and cultures. And there are, in addition, other formulations. There's a variety of powdered form that can be just mixed up for children with G-tubes, which makes it a lot easier than calculating each single food substance by weight. It's just sort of a formula. And in addition, you may have heard of the Atkins diet. That's an alternative to the ketogenic diet. People do become ketotic on the Atkins diet, but it's a little less rigorous and strict than the standard ketogenic diet. And I don't have enough time to go into the Atkins in detail. How does this weird, bizarre diet work? We don't really know, but we know that when you fast, if you skip a few meals and don't take in food, especially glucose, your brain metabolism will shift from using glucose as its main source, because there isn't enough glucose around, to using ketones as fuel. And ketones are breakdown products of fats, okay? And somehow these ketones reduce the neuronal excitability. And so the ketones affect neurons and affect their firing. Going back to some of the mechanisms I talked about in my earlier part, the ketones might affect excitation and inhibition. We don't exactly know yet. Well, how well does the diet work? This is the percent of seizure freedom on the diet. So in maybe a little more than a 6 or so seizure free. Another large group have 90 to 99% seizure freedom, and another group about 50 to 90%. So in approximately half of patients who go on the ketogenic diet, you get at least half the seizures go away. That's pretty good, and it's as good or better than any of the standard drug anticonvulsants that we talk about. So the diet is quite effective. Who should be considered for the diet? Anybody who has refractory epilepsy should at least be considered. at any age, although it seems to work better in young children. Any seizure type or etiology, including Rett and CDKL5. Only a few metabolic disorders preclude use of the diet, and your doctor would go through that with you and test to make sure that wasn't going on. And in addition to epilepsy, the diet has been recently tried for many other disorders, including autism and Alzheimer's disease, so it might have a more widespread applicability than just epilepsy. In 2009, many people involved in the field, we put together for physicians a paper that put together all the optimal guideline managements, and unfortunately I don't have time, nor would you be interested in hearing all of the details about that. But I will draw your attention to Table 1, which is epilepsy syndromes, we talked about, and conditions in which the diet has been particularly beneficial, and there's Rett syndrome, again at that point in 2009 based on some of the data that you already saw. Basically, there's a few case reports on the diet in Rett syndrome. 2 of them are case reports. Those 2 are single case reports of 1 patient. It worked in each one. Then there was, in 1986, actually, before those, a series of 5 patients. 4 of the 5 on the diet had a 50% seizure reduction. That's really pretty good. And parents reported all 5 had better behavior. That doesn't mean it works every time, but it just sort of indicates kind of the trend that's pretty positive. And even in mice experiments, they found better motor function and exploratory behavior in the mouse Rett model. In CDKL5, I found the one report by the Mayo Group. 6 patients all had severe epilepsy. All 6 were put on the diet, and at least 3 out of 6 responded well. So a very modern, recent report about its effectiveness. So in summary, the diet is safe, effective in many kinds of refractory epilepsy. It's not a fad diet. You should not try this at home without supervision. It works by inducing ketosis, the state of the brain using ketones for its energy, not glucose or carbs. And a team approach is really important. It's the physician, the nurse, the dietitian especially, and many other professionals involved with families to make the diet work best. And finally, it is effective in the disorders of most interest to this discussion today. So that's a brief intro to the ketogenic diet. Yep.
Right, so I'm going to talk about some other treatments as well. And I thought it'd be important at this point to reiterate the notion that Dr. Olson mentioned is that in Rett and CDKL5 as well, it's important to understand what it is that you're treating, what type of seizure it is, and is it really a seizure or not. And really the best way to understand this is prolonged EEG monitoring, preferably 24 hours video EEG. It's my personal opinion that if you think your seizures or your spells change and this is happening and it's been fairly regular, it's time to get another one, just to make sure that what's being seen is exactly what everybody thinks it is. So I wanted to stress that. So I'm going to talk about surgery, vagal nerve stimulator, and then talk about some alternatives. So surgery, this is a surgical lesion of the brain. So this is really only indicated if localization of the epilepsy happens to one hemisphere. Now, this is typically not the case with our epilepsies in Rett and CDKL5. So there's no data to support its use in CDKL5. However, if a lesion is found outside of these types of genetic disorders, you can have, if a lesion is found, 70 to 80% seizure reduction or freedom. If you can't find a lesion, but you think the seizures are coming from one hemisphere, 45% seizure reduction. There's been no true efficacy trial in children, as far as I know. Correct me if I'm wrong there. So, but basically, there's a very extensive workup that would happen before you had to have this done. You would have an MRI that might show a lesion or not. There'd be several prolonged EEGs, which would be scalp recordings. Then you'd have additional studies such as a SPECT, PET scan, functional MRI, or a WADA test. And then often there are surface recordings from the surface of the brain, and then there's the actual surgery. Now, what may be more considered in CDKL5 is something called a corpus callosotomy. And this is where you actually make a cut down the main connection between the two hemispheres of the brain. And so often you will have reduced seizure severity, but not necessarily seizure frequency. But it can be quite significant. You can have 90% reduction in 50% of patients with a certain type of epilepsy called Lennox-Gastaut. Many of our patients on the EEG reports will actually have that description in there. So I think it is something to consider if epilepsy is particularly severe. The vagal nerve stimulator, again, for all of these, no studies have been done in our patients, but across the board, varies on the study, but 30 to 70% seizure reduction in pediatric populations. So these are all things to consider when nothing else is working. Just to show you a picture, if you are having a hemispherectomy, then the surface of the brain is exposed and electrodes are placed there, and then this happens in the operating room, and then usually this is closed back up and the patient will sit in the hospital with wires in their head for several days to capture more seizures, to be sure that the seizures are indeed coming from just one hemisphere. The vagal nerve stimulator, it's the brain pacemaker. So there's basically some electrodes that are placed on the vagus nerve, and the pacemaker is then placed in the chest. It's then programmed externally, and you can put a magnet on top of it and turn it on as you need to for acute seizure reduction. So, alternative therapies. This is perhaps a short list. So I think there's some interesting and exciting new therapies coming along. One of them is perampanel, which is, I think, just new on the market to consider. I think this is particularly interesting as we think about where CDKL5 may be working, which is indeed at the synapse. Fenfluramine, stirpentol, and then another possibility might even be something everolimus, which is an mTOR antagonist used in tuberous sclerosis. And then I think that we should consider repurposed therapies. These would be things like NMDA receptor antagonists, which would include things like memantine. Memantine is sold here as Namenda, which is used for advanced stage Alzheimer's disease. Verapamil, which is a calcium channel antagonist. And then I know that you're going to ask me about it because I'm from Colorado, but there are herbal preparations that are often in vogue, such as CBD, frankincense, holy basil. And really, I think that overall, clinical trials are needed. These need to be randomized, blinded, and placebo-controlled. And if we talk about this in terms of such things as CBD, I think this is going to be particularly difficult because it's really hard to mask the smell. So what are the costs of these different things, just in general? You know, a medicine such as oxcarbazepine is $300 a month. ACTH, a course for infantile spasms, can anywhere between be $100,000 to $200,000 for a 6-week course. A vagal nerve stimulator, $20,000. Surgery can be very expensive, $50,000 to $100,000. Ketogenic diet could be $750 a month. Trying to use the repurposed medicines can get very difficult because often, even though I could try to prescribe it for you because it's already going to be on somebody's formulary, but it's often not going to be covered by insurance, and it is indeed experimental. Now, herbals, these would include some of the CBD preparations. Some of our patients are spending upwards of $1,200 a month, and this, of course, is not covered by insurance. Now, what we really need is clinical trials, and these can be quite expensive. These can, cost thousands of dollars per patient for a clinical trial. So I want to tell you a little bit about CBD. So there's no data to support the use of CBD as an anticonvulsant. There is data that CBD lowers IQ in the developing brain. And this is the statement from the American Epilepsy Society, which says, basically the bottom line says, the American Epilepsy Society is supportive of well-designed research to determine the safety and efficacy of marijuana in the treatment of epilepsy. So there's a number of references there. So this is the Colorado experience. Now, this is very preliminary. My colleagues in Colorado were very kind to share with me their data from their AES abstract for December of 2014. And so the title is Parental Reporting of Response to Oral Cannabis Extracts as Adjunctive Therapy for Medically Refractory Epilepsy. This is by Craig Press, Kelly Knupp, and Kevin Chapman. So we're trying to collect our patients because we want to counsel you as best we can. So it's now upwards of 85 patients. And the reported seizure improvement that families are giving back to us, it would not meet FDA criteria for saying this is an effective anticonvulsant. So I didn't want to take their data. I needed to abstract it for you and present it to you, but that's basically the bottom line. They are going to present this at AES, and I don't think it's fair for me to steal their thunder, but I felt that you needed to know this. And it's very interesting that families that moved to Colorado were 3 times more likely to report improvement. And I think that this is interesting because it suggests that there's a lot on the line there. We haven't done this in all of our patients, but this is what our goal is to, as many as possible, we want to look at 24-hour EEGs before and while they're on the medication to determine if there's changes in true seizure frequency or background. We know in all studies that seizure reporting without EEGs is very difficult to do and often over and underestimated. Parents do report improved behavior, alertness, and language. And there have been both mild and serious side effects while patients have been on medical marijuana. These have included status epilepticus and even a patient who died. Now, if I were running a clinical trial and this happened, I would be in big trouble. So anyway, if you can get to the American Epilepsy Society meeting, or at some point, this is hopefully going to come out so that you can see it and it'll be in a bigger form. So that's where we are with that. So here we are. We're at the end. We're time for questions and answers. So I want to thank my colleagues very much for joining me here at the podium to talk about this today, Carl and Heather. So we gave you an introduction to epilepsy. We talked about epilepsy and CDKL5, talked about epilepsy and Rett syndrome. We went through some therapeutic options with pharmacologic, the diet, surgery, and some alternatives. And really, it's now time because we want to open this up for you so you guys can ask us some questions. So thanks very much.
Hi. I don't like being on microphone. Okay. So we've been doing the ketogenic diet for several years, and my daughter has some of the symptoms of GLUT1 deficiency syndrome. In addition to CDKL5, she doesn't have, she's not been tested for the genetic cause of GLUT1 deficiency syndrome, but she has the CSF glucose is much, much lower than it should be compared with the blood glucose. And I get all their updates, and there's something in the works, triheptanoin, that is in clinical trials for GLUT1 deficiency syndrome in regard to creating a ketosis effect without the ketogenic diet, and I just wondered if you guys knew anything about that. I was really excited to hear about it.
I'm not aware of the clinical trial. Is that working, or just my voice? The triheptanoin is called an anaplerotic compound that kind of substitutes for certain other energy-producing compounds. I am aware of literature in animals in which it is effective against seizures, particularly in GLUT1 deficiency, though I'm not aware of that. The questioner is bringing up one of the conditions that almost requires a ketogenic diet, because in that condition the child cannot get enough glucose into the brain from the bloodstream in order to make energy happen. GLUT1 deficiency, it's called, DeVivo syndrome. And in that case, the ketogenic diet often works well because it allows the child to use ketones as his or her energy source when it's not available biologically for them. So it's encouraging and interesting that triheptanoin is being tried clinically. I'm just not aware of the trial. Hopefully, yeah.
And my one other quick question, do you have much data on VNS working with ketogenic diet? Because she responded really well to ketogenic diet, and the efficacy wore off. And then with VNS, we're back up to a really good place. I didn't know if you're seeing that anywhere else.
That's why we need to collect the data so that we can give you answers like that as to whether or not that's the sort of thing that holds up.
I just wondered about what could trigger a seizure. Could pain from reflux trigger a seizure?
That's a good question. There are many triggers of seizures, and different children have different ones, and a lot of times we don't know. It's just an event that happens out of the blue, but we know that illnesses are triggers for seizures in kids who are prone to them. Stress, lack of sleep, pain, I think that's controversial. I wouldn't deny it as a trigger, but many, many different things can trigger seizures, and if the pain is stressful, sure. Would you agree with that?
Oh, I'd agree with that. The one thing that I would add, and I don't know if Heather was about to say this, but sometimes it's hard to know if the patient has Rett, whether or not that really was a seizure, if it's pain induced. And I would often, if I get that story that the family thinks that it's pain induced, it's something that's inducing. I mean, seizures typically often just come out of the blue. That I would really like to know that it is indeed a seizure to make sure that I'm treating it right, and to make sure that if the patient is in pain, the question is why? Is it reflux? What is it? That you need to be very systematic in how you approach this, and we as neurologists, have to take off our neurology hat and try to look at the big picture to understand if it's any of those other things that could be causing it, and it could be in our patient who is just having something that looks like a seizure and really isn't.
Yay.
I would generally totally agree with that, and figuring out what's seizure and what's not, as we've talked about, is very important. Families will report a number of things that we think is seizures, and it's really the pattern that is most helpful. While we traditionally think of pain as not a usual seizure trigger, I've heard that constipation is a trigger for a number of patients. We don't exactly understand why, but it does seem to be. So it's really a matter of working closely with your neurologist. Once a child has a typical seizure pattern, oftentimes families are very good at saying, yes, that's their usual seizure. And in some patients where seizures are very uncommon, we could never capture them on EEG. But it's when there are frequent enough events that can be captured that are kind of in a gray zone of when you talk with your neurologist, you can't say 100% for sure this is or isn't seizure. That's when video EEG can be very valuable, and on an intermittent basis, if things are changing, like Dr. Benke mentioned before, you might need to readdress that.
You've all got them, those cell phones. They're a great thing to use as an adjunct if you didn't happen to be hooked up. And I know it's hard. You're trying to take care of your child, to minister to your child and hold the cell phone up. But having those videos has been very helpful.
I have a quick question. We talked about pain as a possible seizure trigger, but for a lot of our kids with CDKL5, and I would venture to guess with Rett as well, our kids have a lot of GI issues. And I notice in my own daughter, and I've heard it over and over again, that when our children either they've got abdominal distension, or they need to burp, or they need to do something, or they're constipated, then they start to have more seizures. And like in temporally, like for instance, Kira, she would have a seizure, and then she would burp, or she might be really distended and then suddenly have lots of seizures. And I can't say, it must be very uncomfortable, so I kind of think it's pain, but I do know that there is a brain-gut connection. Do we have any understanding or sense of could these be abdominal seizures, or can they be, is there something that's triggering her, is there something in the gut that's triggering the brain seizure? Does that make sense?
Not that we know of, but that kind of leads into the whole issue of how does the vagal nerve stimulator work? So.
There was a question back there.
Okay, hi, I'm Miriam. I have a son, 4 years old with CDKL5. And, excuse me. So my son currently is on the ketogenic diet. He's tube fed, and he uses MCT oil, RCF formula, and Polycose. Polycose has been discontinued. And I'm finding that with different substitutions, his seizures have been dramatically impacted. Apple juice, awful, awful, awful. Cornstarch, just as bad. Polycose has been the only thing that has enabled him to have what I'm starting to think is decent blood sugar levels, and noticing a pattern where he will have, when he has about an hour outside of a feed, a bad tonic-clonic. There have been any studies as far as blood sugar levels in children with, or I guess my question is, A, with the Polycose, in your ketogenic diet understanding, have there been any good substitutes for that? And then number two, have there been any understandings of blood sugar levels causing seizures and how that's impacted?
Those are interesting observations and important ones. You might think if you're not giving someone much carbohydrate or glucose, their blood sugar would go down because they're not getting any in. And that is true to a moderate degree. In studies of children on the ketogenic diet in general, their blood sugars are on the low normal side usually, 70, 80 range. It doesn't drop the blood sugar down zero. So the body has a mechanism to keep enough glucose in the bloodstream for a lot of other functions, even when it's deprived of a lot by diet. That's one observation. Different types of carbohydrates might also make a difference.
Right, that's
And,
exactly what I'm thinking.
I didn't mention anything about the low glycemic index diet, or she likes to call it low glycemic index treatment, not diet, because it's not really a diet. But that's substituting certain carbohydrates with low glycemic indices versus normal ones, and that makes a difference too. And the final question you asked or hinted at was, can blood sugar itself cause seizures? And yes, both way too high or way too low blood sugars in regular individuals without any disorders can also cause seizures. So it is a complex interaction. And those are good observations. Did I cover all the questions?
Yeah, just one quick thing about the Polycose. Have you heard of any alternatives that have really been good outside of what I've already just said?
No, that's the sort of thing I usually work with the dietitians on, and they often come up with good alternatives.
Yeah, mine's got nothing. We've tried a bunch, nothing. I'm
Okay.
just curious if you guys have.
We can ask for
Yeah,
you.
that'd be great. Okay.
Would you say that maybe in this situation that a different diet should be considered, like the low glycemic diet? And
I'm not going to make specific recommendations, but there are a variety of dietary approaches, as there are a variety of medication and pharmacological approaches, and a family and a physician, dyad working together, should consider a whole variety of options that may change over time, as well as you mentioned.
Hi, I'm my student's teacher, and it's been very helpful to know that what we have suspected are seizures may possibly be episodes. The family I work with, they did have a video EEG done, which came back negative, but she's in that 7 to 12 year range. So with the neurologist, is that with her being having Rett's, is that a common process to be done during this time frame, just to kind of keep up on it, or is it something the parents have to request?
So is the question, does she need another EEG?
I guess just to know the difference, what we thought, she would wake up in the middle of a sleep and not be breathing, but be sitting straight up. We'd have no eye contact. And then just all of a sudden, we'd have this huge breath. So it could be apnea, so I just didn't know if this is a standard thing that's done to kind of monitor, or...
It is. I mean, I think that you'd want to have an EEG to be sure, but that sounds an awful lot like a Rett spell to me.
Okay.
Yeah. And it's really just an ongoing conversation with the neurologist who hopefully
Right.
you can trust as to what they've seen in the past and when an EEG needs to be repeated. There's not a specific time interval at which we recommend them. for
Oh, okay.
example.
Okay, thanks.
There was someone in the back who keeps raising their hand.
Hi. My daughter is 14 years old. She started having like seizure activity at 7, but it really never affected her too much. She was actually on the mild R133C, which is mild symptoms. She could walk, she could talk. She was kind of independent. I mean, she had Rett syndrome, but she was doing okay. We started giving her seizure medications just for like night seizures and whatever, nothing really obvious from 7, and we started a lot of medications. She had a lot of side effects, back and forth, we changed. Then she kind of was, she was having seizures, but we were okay. Like, it was not life-threatening. After, I would say, when she was 12 years old, or 11 or 12, when they were actually, she would have to go to the hospital, and the seizures became unstoppable, like 1 minute every 3 minutes for like 24 hours. And we give her we go to Johns Hopkins, so we're at the great hospital, so we're okay, but right now she's taking Zonogram, Keppra, and the past 2 years she was going like maybe every 3-4 months to the hospital with unstoppable seizures. We had to give her phenobarbital, phenytoin, all kinds of things that would actually put her almost on a ventilator just to stop these seizures. We never put her on an induced coma, which to me was awesome, but pretty much after the phenobarbital, she's like sleeping for like a week. So I know my daughter's situation is not the common Rett syndrome, it's very intense. She's on hormones to stop her period doesn't stop, she's on 2 hormones. So we're doing all the treatments possible. So I think for some people with extreme cases, she has the VNS too. So what do we do? Like, to me, cannabis is the only alternative we have left. And I understand there's death and there's, after Bancel that she started taking in February, she actually she's barely talking now, and she has difficulty walking because right in February, every time she goes through seizures, she goes through a month of decrease everything, but then she always comes back. And every year from 7, she's totally lost a lot of skills. And the decay is obvious. I don't know if because of medication, side effects, or all the seizures. It's probably a combination of all. But she's still happy when she's okay. We're still like coming up and down. But at this point, like, what is your advice? I know it's not for everybody. And not everybody should try, cannabis or medical marijuana. But for a situation like this, what are my options? And if there's going to be a trial for extreme cases, like, how do I contact it? Because I've heard it's like for Lennox-Gastaut or for like the most extreme seizure like syndromes, they would do those trials. So what could you recommend, if you could recommend anything? Thanks.
Can I just shift to the question in the back? That's a very difficult situation that you're in with your daughter. But I think that, the other options are the diet still. The question is, when you work with your epileptologist, have you gone through a number of different combinations that might be reasonable? It's just, right now, I can't say that there's any suggestion that medical marijuana will help you at all. It could even hurt you. if not in your pocketbook, but even in other regards. And so we were, we don't have any skin in this game either way. We were hopeful that, something was going to turn up, but so far there isn't anything. But as far as the trials go, I think that they, as you might understand, if you want to determine if there's an effect of a drug, you need to keep your patient population as uniform as possible. So that's why they've kept it to certain groups, like the one trial was mostly with Dravet syndrome. So I think that because they would like to, give that population an answer, and if the population's too diffuse, if you have one or two that might respond, it's not going to show up. It'll just be noise in the data. So my understanding is that the trial with the GW pharmaceutical compound, which is a synthetic cannabinoid, I think that's closed. I think it's filled up. That's the last I heard. So.
I have a question regarding Tegretol. We have, my daughter's been on it for eight years now, and we are having major problems with low sodium. She goes in the hospital fairly regularly for pulmonary issues, and every time we go in, we have to up her dose of sodium. We have fairly good control over her seizures. We do have periods that we go through, we have some breakthroughs, but for the most part, her seizures are fairly well controlled with the Tegretol. When do you get to the point with the sodium that the sodium is more of an issue than the seizures, and you need to start looking for another drug? Do you guys have a criteria when you say that's enough? And also, as long as she stays on the Tegretol, will her sodium continue to drop, or will we ever get to a point where we may taper off and say we're finally, instead of it seems to get there, and then the next time we go back in, it's back low again? It seems like it's just a constant trying to keep up with it, and bumping up that dose. And I know she's an individual and you don't know her, but I'm just saying, do you guys see that issue with other patients, and how do you handle it when it seems to be constantly normal drop? You get it up and it starts dropping. Anyway.
So that is a well-established potential side effect of Tegretol, as well as its cousin medication, oxcarbazepine. And when it happens, it can be a tricky issue. Sometimes coming down on the dose of the Tegretol can be effective in helping that sodium to not be as much of an issue, sometimes not. Sodium replacement is not always the answer. The underlying mechanism is going to continue to drive it down, so it's just an issue. It's a matter of, is the sodium low enough that it's causing side effects like more seizures? Or sometimes if it's just stable at a little bit lower than usual level, we'll leave it there and take the seizure control and a little bit of a low sodium. So it's a balancing act.
So it never seems to get to a maintenance level with the sodium supplement versus the Tegretol. You can't really ever get to it. As long as she's on the Tegretol, we've got that issue. The constant lowering of sodium is normal.
It's not normal, it's a side effect of the medication, but if it's there, it's unlikely to just disappear.
And I think your daughter case is extreme. It's one of the more dramatic ones I've heard of. Normally, children's sodiums do not drop so low or stay so low. So as you said, every child is different, and yours might be on the more extreme side of that. But there will come a time where you have to decide, maybe it's, with your neurologist, time to try another medication. If the Tegretol worked so well, that there are other medicines that might work just as well without that side effect.
Okay, my daughter has CDKL5, and just to add the question that Catherine had, for us it is very obvious the gastrointestinal problems trigger the seizures, to the point that the first years of age that my daughter had, she tried most of the medicine that she could try. So we got into the point that the doctor said, let's stop because nothing is working. And one day I just picked up my daughter when she was having a seizure, and I realized that she burped. And okay, so after seizure, she's burping. So next time, I picked her up when she was almost starting to have a seizure because we knew how was the pattern. So she started to be disorientated. So we pick her up and make her burp, and she didn't have the tonic-clonic seizure. So we started to see, oh my God, this is so interesting. How can I explain to the doctor this? So I did it, my husband did it, and it came to a point that we started to do it in front of the doctors and nurses, and they didn't have an explanation. The EEG was showing, because actually we did it once when it was an EEG, and it showed at the start of the seizure. We lift her up, she burped, and she didn't have the tonic-clonic. So this was so obvious, and for us, we stopped physically seizures for 2 years. So we had to be there on time, because when we skipped the phase of the starting of the seizure, we could not stop it. We had to do it just in the beginning to pick her up and actually make her burp. And she also had these trigger points in the back of the head that we had to massage, and at the same time push the button in the stomach so she will burp. So that was the way we actually stopped the seizures, and she was controlled medically, or no, I would say physically. For us, these gastrointestinal issues are extremely important when it comes to seizure control. So my daughter is on a very strict parent diet, because it's not a doctor diet. We avoid almost everything that will cause gas, including banana and milk. But of course, this, as she was growing up, started to be very difficult for us to physically stop the seizures. So now she is on Topimax, and well, we are from Norway, so Topimax is, I guess, Topiramag, okay, here in the States. So we have come all the way from Norway to hear from you three to know what you think and what is your experience with gastrointestinal issues and epilepsy. But with Topimax, she is basically covered. She doesn't have seizures. But we do see sometimes that even with the empty stomach, she can have seizures or start with the trigger of the seizure. So this is our fear always around about the gastrointestinal. And I would like to hear from you how the vagus nerve works really with this, and if you can explain a little more about that.
Explain the vagus nerve.
So that's a long talk about how the vagus nerve stimulator may work to prevent seizures, I think, and it's still somewhat conjectural in many ways as to how it works. There's the thought that really it's these inputs to the thalamus, and somehow the thalamus shuts down the seizure. But then there's also the other issues of how it's affecting the signals that are coming, through the vagus nerve and the rest of the autonomic nervous system, and I don't think that we know the answer. I think it's very interesting, and I think that this is why for us these sort of conferences are great, to hear from you about what you're seeing, so that we know that we need to be looking for this and to understand from other parents and families. I mean, Dr. Olson and I are looking at each other, and we need to add that to our list of possible triggers to make sure that everybody has the option of asking and making sure that, whether or not they're seeing burping as a trigger for seizures, but also with the other things like constipation as well. I mean, I think this is a question of, or an issue of, we're in such early stages for this that we don't know what the right, we don't have the answers, and we don't often know what the right questions are to ask you in order to approach those as well. But I think that this is something that we need to discuss with our GI specialists to see what sort of thoughts that they might have on the issue as well. I think that what's clear is that what we've learned through the studies is, the initial French study said that GI issues weren't a problem, but our experiences were very different from that, and certainly it was borne out by the Australian cohort. So.
Okay, I want to thank the panelists. I'm really sorry, y'all. We're over time in this room on this panel. Perhaps they might be open to answering some more questions for a few minutes following this. I want to thank y'all very much for your effort and for your time being here today, and I want to thank everyone in the room for their participation.